Let's go ahead and get started. My name is David Migrandasa Arnopole. As Vicki said, I have a master's in nursing. I'm a nurse practitioner, but that's not what this research is about. I was lucky enough to get with Dr. Cooper and got to interact with a lot of people who injected drugs at the syringe exchange in Tennessee. One of the biggest things that I started hearing, which threw interest at me, was their vaccine hesitancy. They would see providers and they would get treatments for their diseases, but vaccine hesitancy became something that a lot of them talked about, specifically about the flu. And this is well before the pandemic occurred. So it got me interested in this research project. So today I'm going to talk about that project. My translational research project was focused on vaccine hesitancy in people who inject drugs. Now, a translational research project being a project that introduces some sort of intervention to a population to see if it changes how they interact or how they are accepted of this change. Today's objectives, I want you to understand what vaccine hesitancy is in terms of my project. I want you to understand the driving forces of my project, the theories that I use, the population that I focused on, and the literature that I used to actually drive this research. And then the study itself, the design, the findings that I was able to occurred, and the application of the results and what it means. Overall, what it means to nurse practitioners and vaccine hesitancy in general. So let's talk about this practice problem, vaccine hesitancy. In this project, I defined it as this: a delay in acceptance or refusal of vaccination despite the availability of vaccination services. Why does that matter? Vaccine hesitancy has been defined as one of the top 10 world threats to the world population by the World Health Organization. Although it itself is not a disease, it is just a viewpoint. But this viewpoint is leading to many, many unnecessary hospitalizations and loss of healthcare dollars. For example, in the 2018-2019 flu season, over 158 million United States individuals were immunized, 35 million people were symptomatic, 500,000 were hospitalized, and over 34,000 people died from the flu. So why did I specifically talk about the flu? Why is that important? Well, the flu is also one of the top 10 World Health Organization threats to the world population. It requires a yearly vaccine. Unlike some vaccines that can be 10 years out or once in a lifetime, it requires people to constantly think about, it's time for my flu shot, due to mutations or other things that are occurring on the endemic changes, or when the virus actually changes. And since 1994, there has been over $1.8 trillion in healthcare savings because of just receiving the flu vaccine. But those healthcare dollars are at risk. With all of that being said, there's one more term I want to define: herd immunity. It's a big term that a lot of people have heard, but for purposes of this project, it's defined as creating a barrier of immunized individuals who protect others who are either unable or unwilling to be vaccinated from preventable diseases. And while there's a lot of other research that can be done, I focused this on people who injected drugs as the special population that I used. Overall, the idea for this slide is this: the more vaccine hesitancy occurs, the less likely herd immunity will occur. The purpose of this project was threefold. I wanted to show that education would actually decrease vaccine hesitancy in people who injected drugs. I wanted to decrease vaccine hesitancy in those people, and I wanted people who injected drugs to recognize their risk from the influenza virus. I wanted to do this through promoting public health, education, helping them understanding washing hands, receiving their flu vaccine, but also to customize this information, not just based on websites, but what they specifically were telling me was the problem. So to do that, I created a PICO, or a question to lead my research: population, intervention, the actual comparison, and the outcome, leading to the question of, do people who inject drugs, who are educated about the influenza vaccine, compared to their current beliefs, show a change in vaccine hesitancy? So all of this helped me guide into the project. I needed to have a theory, something that I could use to help guide this project. So I use cognitive learning theory. The idea here is people's behaviors, people's environment, their personal factors and views can all change and make it difficult or easier to change how somebody sees something. So I use multiple sub-theories: Gestalt theory, social learning theory, constructionism, constructivism. Overall, the main idea for all of this, though, is a focus on learning. How do people learn? And if somebody is hesitant to learning, how do we overcome that? To do this, I was able to go with a syringe exchange program in Tennessee. They had trained volunteers and staff that were all used for syringe exchange, chronic disease management, HIV prevention, hepatitis screenings and treatments, as well as they already had an interest in receiving the flu vaccine to give to their clientele. The issue is it's costly, and these individuals in this organization wanted to use this research to try and write a grant to be able to gain that flu vaccine for their clientele, people who injected drugs. As I'd already said, that population is the people who inject drugs. They had three main criteria to look at, though. They are a high-risk population for influenza. They may lack access to healthcare or refuse to seek healthcare until absolutely necessary. They have a distrust of both authorities and medical personnel who feel that they will actually be identified to the authorities for their illicit drug use. And many times they have a lack of clean running water, making it more likely to have issues. They have comorbidities that could actually cause an issue with the flu, HIV, tuberculosis, hepatitis, just in general being immunocompromised. So if they did receive the flu, they have a higher risk of complications, pneumonia, hospitalizations, and costs related to those hospitalizations. So using all that information, I went into literature review. I used two databases, Cochrane and the Cumulative Index to Nursing and Allied Health Literature, or CINAHL. This became very interesting. I used just a few terms: vaccine hesitancy, adults, and not children, because I didn't want to focus on pediatrics with this. Normally, you stick within a 4-year time when you're looking at research, and I had to extend it to a decade to get enough data. Using 2010 to 2020, I was only able to find 17 unique articles, and I couldn't use them all. I had to go through and look and see. I had to find opinions by public and providers about vaccines, education about vaccines, people's view on having mandatory vaccines, or in general, the vaccine uptake ability of people who have comorbidities, and then again, education. And then I also removed anything to do with pediatric fear of needles and pharmacy interventions related to this. In 2010 to 2020, I was only able to find 10 total articles. So one article per year in a decade on average was the only way I was able to find enough information to actually do this research. Once I did have those 10 articles, I started to analyze them, and some very interesting things came up. Vaccines work, that have always been controversial for one reason or another. If you mandate a vaccine, people are less likely to receive other vaccines. But if you tell people to go look things up on Google, they're more likely to look for things on their own bias. You can't just tell them to go look things up. No education level was free from bias about vaccines. One of the things that I found was anybody with a master's degree or above that were asked about views came up with several very important topics to look at. They felt vaccines were no longer necessary in first world countries, or they felt the vaccines were higher risk than the diseases they prevented. Some felt that education, because of their education, no matter what their background, they could make medical decisions about vaccines instead of having to ask a medical provider who was trained in that. And that also the idea of herd immunity was ancient and no longer necessary. Another key was the education and trust. People need to be educated about these vaccines, and they need to trust who's educating them. However, the research is contradictory on trust and research and education. Education worked better than mandating vaccines, but when vaccine hesitancy itself would not be affected by education and all of that research. Education worked well if there was any adolescents involved, and people would still trust providers to tell them what to do with vaccines, but they wouldn't trust the actual vaccine or the company making the vaccine, or any sort of government agency that told them they needed to take it or should take it. In general, there was a very interesting gap when I started looking at this. people who inject drugs. If I added that to that original research, there were 0 articles. If I did find an article on them, the most I found was 5% of the population that was used in the sample would be people who injected drugs. But they themselves have unique stressors. They have a fear of legal repercussions, being identified, and have to actually deal with this situation of any sort of legal repercussion related to it. Fear of being reported, not just to the police, but Child Protective Services or anyone that would actually take anything from them because they chose illicit drug use. And a mistrust of anyone in authority, including medical personnel. So the next logical step was to focus on people who inject drugs only, and to ensure any sort of material I did was not generalized. It was only based on what they told me was important to them. To translate that into practice, I wanted these individuals to begin to trust medicine and to show education could overcome any sort of vaccine hesitancy in this population. With that information, let's take flight inside of this project. The design and implementation. The design was a pre and post survey. It was under 3 phases. Phase 1 was 2 weeks, a pre-intervention survey, which you will see in a few slides, specifically asking every individual that came up to the syringe exchange several questions about the flu vaccine and their view on it. It helped identify themes that allowed me to educate in a later phase, give me some demographics to look at when analyzing data, and also to gain some data for comparison in that 3rd and final phase. The educational intervention was 2 more weeks. A poster was created and a pamphlet was created. All the data in that pre-intervention survey was used to identify themes to create the poster and pamphlet, only based on what they specifically told me they were worried about. And then the post-intervention survey was another 2 weeks to help measure any change in vaccine hesitancy. Both Phase 1 and Phase 3 used the exact same survey, except one said pre and one said post-intervention. I was able to get 310 individuals to be part of this research. This was done with a convenient sample, so every single person that approached for syringe exchange was questioned with the survey, and then there was implied consent. The first question they were asked is whether they were willing to actually answer some questions or not. And if they wanted to end at any time, they were allowed to do so or simply say, no, they didn't want to be part of it. CDC guidance was followed at all times with this. Masks, social distancing, hand washing, and research equipment. Everything was used by myself only. I would answer the questions of the individual. I would ask those individuals their questions. I would write everything down to also help de-identify any data so they didn't have to worry about their hands receiving anything, or some people were actually worried about getting their fingerprints on the paperwork. So only I was the one that touched this. This was done in a syringe exchange clinic in Tennessee. There were both scheduled appointments, walk-up appointments, and differences between there, which did cause some limitations we'll talk about in a little while. But this was done between December of 2020 and February of 2021. This is our little pup there. This is Brody. He was our syringe puppy. He was there for every single day of this syringe exchange to help people feel a little bit more comfortable with this. But on the right, you can actually see the questions that were asked of these individuals. Questions 2 through 4 were demographics, age, highest level of education, and did they receive the flu vaccine last year. Question 5 was actually used to actually measure those differences. Do you feel the yearly flu vaccine is necessary? And question 6 was an open-ended questions where people got to actually tell me their actual views and allow me to identify topics and themes. This was not just an arbitrary questionnaire, though. Reliable and valid. The reliability idea is when you make a survey, you want it to consistently give you the same results between those sample populations. And you want it to be valid. So if I were to ask questions of one sample population, it would actually pertain to the entire population rather than just the sample. It used face validity because this was with permission from Dr. Opel. He created this survey to focus on all vaccines, and I altered it slightly just to focus on the flu vaccine. And then there was also inter-rater reliability, meaning I just simply always use people who inject drugs as the population. There were a few other types of reliability and validity used in this research, but those were the 2 main ones, face and inter-rater. This was the educational pamphlet trifold that was created based on that first phase survey. Some highlights of this were how to prevent the flu. People didn't understand what occurred. People wanted to know how to prevent it, what they needed to do. So topics in here including sneezing into their arm, not touching their nose and mouth, receiving the vaccine, hand washing. Another topic was major side effects. People felt like the flu vaccine caused the flu. So I talked about headaches, becoming a little sick afterwards, and how that is normal, and how that actually was occurring in their body, and you wanted that kind of thing to occur. And then, why do they need the flu shot? Explaining why it needs to be done every year. This was the poster that I created. This was more of a large poster just to kind of get them interested in coming and talking to me during the educational phase. In terms of financials, the cost of what I anticipated versus what I actually incurred is there at $352. They were the exact same. Most of the cost was actually related to time and not monetary value. I had to print a lot of different things, but I spent a lot of time with different individuals. So let's get into this data. Let's actually see what we found. The descriptive statistics was used for demographics, questions 2 through 4, to see who we were actually interacting with. I used chi-square analysis to help review the differences between phase 1 and phase 3. That specific question of, do you feel the yearly flu vaccine is necessary? And then I helped identify themes to review that of question 6, that open-ended, tell me your thoughts about you receiving the flu vaccine. Again, 310 individuals were part of this. In phase 1, there was 146, and in phase 3, there was 164 individuals. So, 2 big things I want you to catch on this. In terms of gender, it was about half and half. So the pre-intervention phase was about 50% female and therefore 50% male. And in the post-intervention phase, we actually had a slightly more males than females at 44.1% female. The other piece was the idea that these individuals were either between the ages of 29 and 39 as a majority in both phases, or had a high school education being their highest level of education. Here's the interesting part. So this is the chi-square. This tells me the difference between phase 1 and phase 3 in terms of data. Comparing that pre and post, in phase 1, 52.5% of individuals felt the flu vaccine was necessary. Education occurred, 2 weeks. Only 36.6% of individuals felt the flu vaccine was necessary after I educated them on how it was necessary. To identify some themes that did mirror this idea, on the left, on this graph, you can see the blue and red. The blue is phase 1, the red is phase 3. These are the topics I was talking about. So rather than define every single statement that everybody made being put onto this graph, it was every statement was generalized into one of these 6 categories. Whether the statement was pro-vaccine or felt they were too healthy to receive the vaccine, feeling the vaccine themselves made them sick, a lack of trust, and financial environmental reasons not of the vaccine, or just no response. You can see here, 41.7% of individuals in phase 1 made a pro-vaccine statement, where in phase 3, only 36% of individuals made that statement. And then the makes me sick was the other topic, where 19% of individuals felt the vaccine made them sick in phase 1, but after the education, it went up to 29% of individuals felt the vaccine made them sick. Break this out further, just to kind of get a little bit more of a view. This is the pro-vaccine view, around 42% in phase 1, down to 36% in phase 3. And then the makes me sick, feeling that, making a statement that the vaccine made them sick or gave them the flu, went from 19% up to 30%. So 3 key results with this. These individuals felt like the vaccine made them sick after the education. This may have been related to a disinterest in the education that I gave, or a lack of trust. As I had said, I was already there. I had been there volunteering for over a year at this point, but they just may not have trusted the information being given to them. There was no increase in understanding of risk related to that influenza virus, related to an unwillingness to change views on vaccines. There are some limitations, we'll talk about this, but it may not have gone through that cognitive learning theory where I was able to overcome that hesitancy. And then that statistical significant decrease in belief of flu vaccine necessity. Education is not always effective, especially one time. So let's talk about those limitations. COVID-19, small little thing that occurred, the pandemic. There was a lot of different changes occurring during this time. The organization made changes on an almost daily basis, specifically on the syringe, how it was going to be scheduled, whether it be walk-up, drive-up, appointments, phone appointments, online appointments. It kept changing for the clientele. So that was a limitation of making sure everybody who could have been part of this would have been part of this. Vaccines are still controversial. CDC, World Health Organization, they all talk about needing to have these vaccines, period. However, CDC was changing regulations on COVID-19 on a daily basis. So there could have been that fear of not needing that flu vaccine because they don't quite know what they're doing with COVID, so what would they need to do with the flu? This also became a very political topic during this time. Vaccines were very politicized, whether it be about whatever vaccine it was. Now, cognitive learning theory requires a willingness to adopt new information. So during a political topic, it can be shown that sometimes during political seasons, it's difficult to change people's viewpoints. And socioeconomic factors. Social and community context. People could have felt that they were marginalized. They may have just said something to me or just answered based on how they felt. But they also could have feared being identified to law enforcement, so they felt criminalization could have occurred. So they just may not have answered truthfully to help remove that chance of identification. The discussion of this. Education may have actually led to an increase in vaccine hesitancy, but there's no real way of knowing if that specifically caused that or not. One of the big things to note was in 2019-2020, there was an actual decrease in flu diagnosis from 7.1% down to 1.5%. This could have been related to hand washing, social distancing, mask wearing, but this could have been related to that change. That change in pro-vaccine drop views and that makes me sick views increasing, an increased need for education and population regarding those vaccines are necessary. And then new methods that need to be looked at, whether it be incentives, posters and pamphlets, lectures, lotteries like in Ohio and California. Some research showing that it's actually working, those lotteries, some research is showing it's not. It's too early to tell. So I have a couple questions for you all. First being, is it possible that vaccine incentives change the way vaccine education is provided?
I think so. Vaccine incentives may take the place of education. If you are offering people money to take, or a lottery, whatever, to take the vaccine, they may not care about the education and understanding why this is important. So with the flu vaccine in particular, because it is a yearly vaccine, if we do it this year and then the next year we do not, if they don't understand the importance and receive the adequate education, would they continue to get their vaccine to protect themselves, especially in the population you're talking about? So is incentives the way to go versus education? Obviously, as healthcare providers, we understand how important education is, and patients and our population understanding why we need them to do what we need them to do.
So one of the big things there is the idea that incentives, I think, will change the way education is provided, but I don't know if it's positive or negative, because as you said, they're more likely to simply receive that incentive and not really learn anything from it. And again, if you go to the next year and they don't get incentive, what's pushing them to actually receive that vaccine? Other question is, what other methods of education could be used to overcome vaccine hesitancy?
I think you have a hard population there, right? People who inject drugs, kind of there for that syringe exchange piece. They want to get in and get out, right? Could be a fear of, I don't want to be seen. I just want to go exchange and get out. So I think maybe your pamphlet, I think, is your biggest benefit to that. It's a quick synopsis. Now, realistically, how often did they throw that away when you did that? I'm sure it was a significant amount.
It was very, almost every day there was some. Yes.
Having worked with this population, It also has a seasonal component because your research occurred over a period of time. And in Knoxville, you see the movement of different people during that time frame because the people you educated may have moved on to another locale. So there's no guarantee that the post-intervention were the same population.
Yeah, one of the biggest issues we had was the idea that there was a break because of COVID and the holidays where the syringe exchange was closed. So we actually, once the education happened, there was a lull before I could actually do the post-intervention survey. So that was another issue that could have come up. Did you?
Yeah, I was just gonna mention that, you have different populations. That population likes immediate satisfaction. So the reward would be more enticing for them, whereas you have a population that's older and they're thinking more futuristic, like, I want to remain healthy, So I really think you have to have both types of education to get everything.
Whoa. Three, go this way, because she was next, go over there.
Sorry. I think kind of combining both of your questions, I think you've got some great ideas and it was very interesting. The outcome being not what you predicted, in the sense that I think that the education with this patient population may need to be more of a dialogue rather than a flat surface. Because I think that you probably had some curiosity when they said, well, you saw those results coming in, and you're like, okay, well then tell me why you feel like you're gonna get sick. And maybe just one more little piece of dialogue could have pushed them over. And I think the last speaker had a great point, that immediate gratification, right? These people are not going to participate in a lottery, right? They're not going to see the benefit of getting a ticket and then checking it and then checking the website to see if they won something. They're going to want something right away, like whether it's a $5 or a $20 gift card to some service, they're going to want that benefit. And giving the flu shots immediately, like, okay, you want one, let's do it now, could be a way to kind of capture that patient population. But it is very tricky, and this is a remarkable research. Thank you.
Yeah, that was one of the biggest things I wanted to see is if an education method would do it. But in the syringe exchanges, some people had said, they come in, they get their syringes and they leave. So it's a little difficult to spend time with them than more than you need. A couple of questions over here.
Yeah, I had a question. So I just want to make sure for clarification. So you did the pre-test and then you did the education, but it might not have been the same people who
Correct.
took it, got the education, and then did the post.
Correct. The idea with cognitive learning theory was to educate everybody I could, or ask the questions everybody I could to get as much information, educate them, and allow them to disseminate that information using cognitive learning theory to go over their peers and show peers specifically that this is there for them. I didn't know if this population was going to do that. This was one of those tests to see.
Okay, so you didn't, so the whole thing is the people who took the post may not have ever gotten the education.
Correct.
So
yes.
the data could have been incredibly skewed, I would think.
Correct, yes. And that was the issue and especially with that break because of the holidays, it was difficult to make sure who got what, and people do tend to transfer around in this area because of that, which again was the idea of cognitive learning theory. Hopefully the information got to these groups and they could come back and actually answer those appropriately.
Okay, but you don't know that. So there was a question on there that asked, have you had any education on that?
Correct, there was not.
Okay, and then my other thought is, then you're relying on those people to do the education who may not really understand it.
Correct, yes. And that's the idea of this is more of a dive or of a springboard to go further with that education, because this organization is very interested in educating. So this is something kind of showing that maybe they should kind of use this as a serial education moment.
Well, another thought is, since DMP is just a time limited, program, is to have maybe another student pick up your research in the future and try to maybe streamline it so that, the people who are doing the pre are the people who are getting the education, who are also the people doing the post. So it might be something that you've just started, something that could be continued.
Correct.
Yeah, David. Also, we had a lot of discussions about this, so you've got some very good points. The situation, though, is this population is transient. It's not going to be, it will never be the same people in 6 weeks in a row. They're always going to be different. But it is the same population of people who inject drugs. So having to look at it from a broader viewpoint is something that Dave and I discussed at length.
Ad nauseam.
Yeah, really, because you can't guarantee that it will be the same people. Now, to repeat the same project would be very beneficial to see what happened with that. So I think that's a very good point.
It would be interesting to know if any of the people in your post did the pre and the education. That would be interesting.
Anecdotally, I can say yes, but statistically, I can't answer to that because I know who was there during those times. Some were, but I can't say specifically and statistically, statistically that they were or not.
Great job. So I remember back like in 2006 when you were kind of tossing around this idea, and I think I thought it was timely then, but who knew we were about to embark on a huge global pandemic and vaccine hesitancy become such a hot topic. I think that one thing that you found in your literature search and literature review, and then pointed out nicely in this presentation, is that there's like a huge gap in the literature about this population. And I think we had talked previously about that just being, in general about vulnerable populations. So I think, a lot of times when you don't come up with the findings you anticipated in your research, that is a great finding in itself. So, maybe just about realizing that that what we interpret to be or assume to be important to certain populations may not be. And so I think that's a great finding, that what may work in one population is not going to work with this vulnerable population. And then, I think it'd be super to do more. I love that you had a qualitative component on your survey. But to expand that, I know that there is a big gap in qualitative research of vulnerable populations. So I think sometimes we just need to dig further into that and figure out what exactly is within their value system that would work, and what there may be something even more than the education, or they may have used different words for that. So I love that you put a qualitative component to it. But I think that second question there could be an entire research study on it.
Absolutely.
For the next folks that want to pick up the baton
Yes.
and run.
Yeah, great job, David. The interesting question to me is the second one also, is what other methods of education could we use? And maybe not so much a method different, but a message. Maybe use more pathos, since certainly we've been immersed in this pandemic now for almost 18 months, I guess 18 months. Have you seen the move toward appealing to one's emotion? There's a video of a young man named Travis. I haven't seen it, but I hear all about it. I think he's from Bristol, and he's a survivor of COVID, but anyway, he's pleading for people to get their vaccination. And that's an emotional appeal. We've never done that with flu shots. You don't see people on TV saying, I've had the flu, I'm now headed for a lung transplant, and I have all these limitations. That has never happened with measles or flu or any of those things. But we're seeing that pop up all the time. And much research points to the fact that we as human beings have much less empathy for groups. We just can't get there. But if you point out one individual, one child who's starving in India, our hearts open up. So when your mama said, eat all the dinner on your plate because people in India are starving, that really didn't hit. But if you focus on one person and their story, then that hits us. So an appeal with more of a pathos approach may be helpful.
It may have worked for some individuals. I see that this population may be difficult with pathos, but it still could be done, just depending. Absolutely. Was there any other questions or comments on that?
Hey, David, this is actually Dr. Knowles joining remotely. Can you hear me?
I can.
Okay, great. Obviously, I just want to echo some of my colleagues' comments, and just I'm super excited to hear the work that you've done on this. My heart and passion in public health and vulnerable populations, I'm jumping up and down right now. So I'm glad you can't see that. But my question that I really had for you is, and maybe I'm jumping the gun, you may talk about this in a minute, but I realize that you're at the end of a long journey and want to finish this journey. But have you thought or considered about your next steps that you would take following or based on what you've learned from this information? And do you have any plans for expanding this in the future?
So the organization director and I had talked about this. She and I are interested in expanding this further and talking about this after this entire project is completed.
Okay, great. Thanks so much.
Yes.
And if you do that, I know the DMP timeline is very compressed, but would you have to wait 6 weeks in between phase 1 and phase 3?
No, the idea was during phase 1, it was an entire 2 weeks. And then phase 2 was another 2 weeks of
Right.
education. No, I wouldn't, and I wouldn't.
A quicker turnaround, maybe we have the same group even during the same day, maybe?
Well, the idea there would be serial education would be the next step, would be constantly, rather than just one time, same group, I would want to continuously, and with those individuals as part of that organization, I would want to train those individuals to be educating them every time that they're there for serial education. Just like primary care does, talking about preventative care, same idea for this. That is one of the ideas that we're running around with.
Yeah, and I'll also say, working with the same organization, David encountered massive barriers. Besides the pandemic, is the mode of delivery for this organization changed significantly. So if someone was to recreate it, it is more of a stable appointment, but they never know exactly the same population is coming 1 week to the next, and they have no control over that. But there are things that would be smoother if the pandemic was not going on, if they didn't have to shut down, and if their mode of delivery was constant.
Yes. Will you keep us informed about the grant? Because that would be fabulous.
Yes, absolutely. And that she's going to use this to kind of apply. I know she's in the middle of writing for that grant with this research. So.
Not to drag this on any further with my own comments, but great job. Very impressed with this work. Just a thought, if you do continue, based on what everybody has said, I agree with their comments. And if you do move forward, I would encourage you to look at the work that has already been done with a different population, but in public health with similar circumstances that may present compounding variables like what you have discovered here. And that was with pregnant teens. And they used real-time interventions to capture, not necessarily learning, because that, implies a more of a constant, but a change of mind about something. And so utilizing film as a delivery method of the information, so you don't worry about literacy. You do have to think about language barriers, but using film while they're waiting, possibly to share a message. And so there was a pre-test and a post-test done during that one visit time. That was very effective in delivering information. So you do have the same sample, the same participants throughout, and you're really able to see, was there any kind of change in biases or opinions about these things. Really interesting way that they approached that, because that was a more transient population too. There was no guarantee they would return to the clinics, but great job. So just that little plug if you decide to move forward with
Absolutely. Thank you so much. I'll look at that. The difficulty, of course, being, as you saw in some of the photos earlier on, it was in the middle of December to February in a parking lot while they were building their new building. So people came in, they got syringes, and they wanted to go somewhere warm. So let's conclude some of this information. The intervention may have actually led to that increase in vaccine hesitancy, but there were a lot of other compounding situations that could have caused the situation as well. A single educational intervention may not be enough to improve vaccine hesitancy. As you've all come up with ideas, whether it be a video or whether it be doing serial education, something else needs to be done. So further studies based on this. Identify reasons for vaccine hesitancy. Is there a lack of understanding in the disease? A lack of understanding in the vaccine? Or what the vaccine specifically does? Is there just an unwillingness to learn about vaccines because they've been always told that vaccines are bad? Or can they identify true versus false information? I can give them a video and talk to them all day long, but if they can't identify if something is true or false, Can they actually take that information that I give them and change how they think? Let's look at the implications for practice. Advanced practice registered nurses are in a very unique situation. We get to focus on the entire person, not just the medical aspect of it, okay? We look at risk factors. We recognize a person's risk factors, their lifestyle choices and how it affects them, and complications that occur based on lifestyle choices and their risk factors, and then we get to educate them on what could occur. We cannot mandate or force them to do something, but we can tell them what could occur if they don't listen or change their behaviors. In terms of practice, vaccines are absolutely necessary, whether it be flu, COVID-19, or their regular shots. We need vaccines to protect the person and the people around them through herd immunity. And we need new methods to educate, not just one time and done. Could it be serial education through this organization, through primary care? What about incentivizing? It's difficult to research incentivizing because there are limitations on incentivizing itself. The educator needs to be competent with that vaccine information, not simply saying you need this because the CDC says this. They need to be able to tell them, this is why you need the vaccine, this is what could occur without the vaccine, and what you're doing, what the vaccine is going to do for you. And the educators need to be trusted. We need to learn the cause of the individual hesitancy, not the entire population, because everybody's different, and allow learning to occur. It's not going to be a sit down, one and done, but with the limitations of time, that's what this attempted to do. So for some future studies, vaccine hesitancy, trying to find a way to overcome this. Other studies need to specifically look at, are they hesitant to the flu vaccine or all vaccines? What specifically is causing the issue? And find out ways to overcome one vaccine hesitancy or all vaccine hesitancy. Look at new methods, serial, in-depth incentivizing, lectures, videos. Review the ability of participants to understand facts versus falsehoods related to this type of scientific information. Let's talk about dissemination. You got to see my poster, you were able to see my pamphlet, and this exact same organizational presentation was done for the organization's director a few months back. The poster for this was submitted to Sigma Theta Tau. It has been accepted, and I will be presenting it in the 15th Vaccine Congress for Lake Garda, Italy, later this year, and was also submitted to annual conference of DNP, Doctors of Nursing Practice.org. The manuscript was submitted to Social Science and Medicine and has been accepted by both the Virginia Henderson Repository and the Doctors of Nursing Practice.org. I also do have an interest in public speaking related to this, and the entire paper and presentation has been posted on my ePortfolio. Here are my references related to this, and I'd like to thank everyone for coming. Thank my chair, Dr. Odell, my committee members, Dr. Cooper and Dr. Clapp, my wife, my son, my aunt, my mother, and my brother from another mother who couldn't make it, Clarence. And the floor is open for questions.